have the honor of speaking with Dr. Joseph Wu today, who is the director of the Stanford Cardiovascular Institute, where he leads pioneering efforts in understanding cardiovascular disease mechanisms, accelerating drug discovery, and advancing precision medicine through innovative approaches like the clinical trial in a dish concept. So in your keynote that you just gave, you emphasized how induced pluripotent stem cells, when combined with AI and genomic approaches, are accelerating precision medicine. And so maybe can you walk us through how these technologies come together in your research and also what it means to understand the disease really on a truly individual level?
I think, as I mentioned on the talk, that these days it's so easy to do whole genome sequencing for research application. Probably costs you about $300 to $400. I have my DNA sequenced myself, and it'll tell you, what type of variants, what type of mutations you have. So that provides a roadmap, especially for patients who have some type of diseases. But once you have a roadmap, you need a way to validate that, especially in the case of genetic variants. You need to figure out what is the impact of these genetic variants. Obviously, you can manipulate that in patients, but now with the iPS cell technology, essentially you take patients' blood, generate the iPS cells, differentiate to whatever cell types you want, and then do genome editing to help you figure out what is the functional impact of those variants. Once you confirm a lead target, and once you have the protein structure, for example, you can then do AI to help you screen for drugs that bind to that particular docking site. I think it's probably faster than the traditional technique of pharmacology. I received my PhD 20-something years ago in pharmacology, in which you pipetting drug by drug. So it's really a powerful tool combining genetics, stem cell as a test bed, and AI for your high throughput screening of drug targets. Yeah.
And so depending on that, can you maybe walk us through how you select your models? So you have worked with very different models. So is it also something where you're like, okay, depending on the output that we're generating, we go from simple model to complex, or what is your approach?
Yeah, so I'm a clinician. I'm a practicing cardiologist. I think the model goes from A to Z. And most of the time people say, oh, I got a new genomics algorithm, and I got a new proteomics algorithm, and this algorithm can then come up with new drugs. In reality, it doesn't work that way. In reality, when you go from A to Z, you have to understand what is Z. Z is your patient, and patients with some type of unmet needs. If you have patients in which the disease already have 10 or 20 drugs available, there's no point going after it because you can't make a dent. You can't even get into the market. So you want to figure out what is the patient population, what is the disease you want to treat, if there's any existing therapy, and hopefully there's no existing therapy, and this then creates a value for the project that you're working on. For me to come up with this drug or this gene therapy or the cell therapy for this disease, what is it I need to do to show the safety and efficacy, and then again, work your way backwards. Yeah.
And in what way do you think being a clinician changes your point of view in your research?
Yeah, so as a clinician, I see patients with different types of diseases. I'm a cardiologist, and we see patients with heart failure, with genetic cardiomyopathy, with cardiac arrhythmias, and high blood pressure, and cardiometabolic syndrome. It changes my viewpoint because anytime when I see patients who have, I would say, quote unquote, strange or weird diagnosis, I, as a physician scientist, I can go back to my research lab and figure this out. And this is part of the joy, part of the joy of being a physician scientist, because you straddle both the clinical realm and also the basic research realm. And it gives me a lot of pleasure to see a patient and scratch my head and say, I don't know what's going on, but I could figure this out for you. Yeah.
And so maybe a word about in the past 2 decades, I think we have seen some really game-changing advances in iPS technology, and this also includes, like you also pointed out, gene editing tools like CRISPR, and now the rapid integration of AI into biomedical research And from your perspective, what do you think is the next big transformation in the field that we can expect or that is on the horizon? And is there an area where you believe scientists and institutions should be focusing and paying more attention to right now?
Well, that's hard to say. I think if I know that, I would be, I'll be on my way to Nobel Prize. I think there are just a lot of advances. Certainly, for the past 3, 4, 5 years, the AI field has jumped dramatically. And I mentioned about the Nobel Prize in chemistry and Nobel Prize in physics were also given to folks who are doing AI. And you will continue to see advances in AI, and you will continue to see how people take advantage of that, integrate it with the biology. So this sector of biotech, AI tech, I think it's going to be very hot in the future. And I think especially for this audience in this particular meeting, talk to your colleagues who have experts in computational background. Talk to your colleagues who have expertise in gene editing. Talk to your colleagues who have expertise in chemistry and protein drug design. And this is what I certainly do. I just enjoy talking to all my colleagues and be able to bring it together so that we can solve a question, go from A to Z.
And where do you see the importance of standardization in this, or do you see an importance?
I think for standardization, it's quite important, especially if you need to communicate to the FDA and say my test is valid. To standardize, you need to make sure what type of SOP that you're using so that everybody abides to that. And so this is very important. And I think, again, the purpose of this meeting is to bring everybody together and kind of start discussing how to standardize some of these assays. And certainly the CIPA initiative, Comprehensive In Vitro Proarrhythmia Assay Initiative, done by the FDA along with about 10 or 11 big pharma. They've done that in terms of standardization of testing drugs and iPSL-derived cardiomyopathy.
So you obviously have mentored a lot of scientists who also became PIs then afterwards themselves. And so what would you say is kind of your emphasis in monitoring or in also mentoring young scientists today, especially with the field that is so interdisciplinary and where you have to be an expert in so many fields?
So I've trained about 60 postdocs who now become PIs. And this year we got very lucky. We have 6 postdocs who are leaving, one going to Hopkins, one going to WashU, one going to UCLA, one going to UT Southwestern, one going to Ohio State University, and the other one going to McGill University. So I'm very, very proud of all these 6 trainees who graduated from my lab this year. I think the model I try to instill upon them is 3 words, 3 phrases. You got to work hard, you got to work smart, and you got to work together. And among these 3, working together is the most important thing, because science only advances as far as you understanding that you as individual PI or person cannot know everything. And that's why you got to reach out to other people. And we have a pretty large size lab. So the postdocs in the lab all know that they need to reach out to other postdocs within the lab and outside the lab to practice the skill of working together, which is essential when they become a PI, because you got to be able to reach out to other PIs within your own university and also other PIs outside the university to foster this type of collaborative spirit.
I mean, that's a strong message. And thanks so much for the interview.
Oh, thank you so much. Thank you.
Enjoy your evening.
Oh, thank you. Thank you.